Hello, everyone. Welcome to this virtual tumor board. It's a pleasure to bring together international faculty to discuss these cases. Before we get started, we'll just do a round of introductions. I'm Dr. Benjamin Levy, and I'm Associate Professor at Johns Hopkins School of Medicine, a thoracic medical oncologist. I am joined here today by, again, a fabulous international group of physician scientists. We'll start with Dr. Sanjeev Bala. You want to introduce yourself, Dr. Bala?
Yes, hello everyone. My name is Sanjeev Bala and I run the Cardiothoracic Radiology Division here at the Mallinckrodt Institute of Radiology at WashU in St. Louis. Nice to be here.
Great. Dr. Wally Curran?
Hey, Dr. Levy, good morning. My name is Wally Curran. I'm the Executive Director of Winship Cancer Institute here at Emory University and chair of the Department of Radiation Oncology.
Great. Dr. Varun Puri?
Hi, Dr. Levy. I'm glad to be here. I'm a professor of surgery and a thoracic surgeon at the Washington University in St. Louis.
Great. And Dr. Mark Socinski?
Yes, Dr. Mark Socinski. I'm a thoracic medical oncologist and the executive medical director at the Advent Health Cancer Institute in Orlando, Florida.
Great. So let's get started. Our second case is a 76-year-old male reformed smoker with a history of stage 4 right-sided squamous cell lung cancer with metastatic disease to bone, lung, and a gluteal mass, as well as the adrenal glands. His PD-L1 is 80. He's treated with pembro, a la Keynote 024 trial, and then sequenced after progression to carboplatin paclitaxel, now having progression on scans after completion of chemotherapy. And I think the question here is, what do we do third line? But we will try again to pivot at each sort of stage of the case, hit the pause button and ask management questions, hopefully from all of you. So this is a 76-year-old male who presented with a right gluteal soft tissue mass. He had some weight loss, weakness, and right hip pain. He has an ECOG performance status of 1. His past medical history is consistent with hypertension and COPD. He's a former smoker. He's got a heavy pack year history of smoking. His family history, he does have a family history of lung cancer. His father died of lung cancer at age 71. Mother died from heart disease at age 67. Now based on his presentation with the pain in his right gluteal area, the patient does get actually a CT scan of this area, but also gets a CT of the chest. This is followed again by a PET CT, and we'll talk about the biopsy that occurred in between. But for the sake of time and grouping things together, I'm going to have Dr. Bala review his CAT scan and his PET scan, at least part of it.
Well, thank you, Dr. Levy. So you can see on these images, on the lung window, an arrow is pointing to a lower lobe mass that this patient had. And on the second image from the FDG PET, there's uptake in some hilar lymphadenopathy. But the dominant finding that was presented is on the bottom image, which is a post-contrast image from an abdominal pelvic CT that shows a mass with destruction of the posterior iliac and right hemisacrum kind of extending into the gluteal soft tissue. So that explains the gluteal soft tissue swelling that was experienced. And that mass in the pelvis was about 12 centimeters. What isn't shown on these images is that there were some other osseous lesions as well as some other pulmonary tiny nodules that were present. But the big thing is a large right lower lobe mass with hilar lymphadenopathy and a very large pelvic metastasis that's mostly within the bone, but has some extension into the soft tissues.
Thank you, Dr. Bala. So as mentioned, his CT chest, abdomen, pelvis shows this right lower lobe mass, a 12 centimeter destruction lesion on the right side of the pelvis. He's got multiple osseous lesions, and as well as, again, a confirmation of this destructive lesion on the right side of the pelvis. Also has on the PET a confirmation of the right lower lobe, the right lung mass. He has a brain MRI, which is negative as far as full staging. In between his CAT scan and PET scan, he does have a right gluteal mass biopsy, a core biopsy. Again, this is a squamous cell carcinoma, most consistent, a non-small cell lung cancer, most consistent with squamous cell lung cancer, and his PD-L1 is 80%, a high PD-L1 of 80%. So this really falls, I think, under the guise of the medical oncologists with potentially the radiation oncologist as well. Maybe we can start with Dr. Curran. He's having a lot of pain on that right side. There's a huge destructive lesion there. Can you talk to us about how you manage these very large lesions in the pelvis and potential toxicities of radiating something that large in that area?
Sure. So this, in my view, may require a more aggressive radiotherapeutic approach than a typical, more discrete skeletal metastasis, because this is a large, mixed, soft tissue, osseous mass. And I am guessing that unless treated as effectively as possible, will probably influence the quality of life of this patient as much as any of his tumor lesions. My view is the best way to treat this and keep the toxicity low is to give the same attention to radiation treatment planning and delivery as you would a patient who had perhaps a sacral-based primary tumor. In other words, do CT-based treatment planning, use non-conventional fields, don't just treat anterior, posterior, use either IMRT or oblique fields, and perhaps push the dose above a typical palliative dose of 30 gray in 2 weeks or 20 gray in 1 week. I think you would want to be able to give a dose that's more equivalent to a 50 gray in 5 weeks type dose, perhaps with shrinking field technique, in order to really give this patient the best chance for a good quality of life. What you're trying to avoid is bowel toxicity, but there is a way to treat sacral area and spare the bowel anterior to it.
Dr. Socinski, Dr. Curran has finished the radiation. We now know there's multiple competing strategies in the front line for treatment-naive patients, independent of PD-L1 and PD-L1 high. What's your go-to regimen here? Are there competing strategies that you would use, and would you employ those competing strategies based on particular types of patient? If the patient was younger and more fit, would you use one regimen versus if they had more comorbidities, would you use another?
Well, Dr. Levy, how much time do you have? There are lots to talk about there. So
I love cutting you off, so just go.
Okay, yeah. I mean, in this particular patient, as I was listening to the case, this is a gentleman who needs a response. I like Dr. Curran's strategy with regard to getting control of that lesion, because if that lesion gets out of control, I think there'll be some major quality of life sorts of issues. I would tend to favor using chemo immunotherapy. My standard regimen in the squamous, I use carboplatin, nab-paclitaxel, and pembrolizumab based on the KEYNOTE-407 trial. Again, he has multiple osseous mets. He's got a dominant osseous mets that's causing quality of life issues. He's got bilateral pulmonary nodules. This is a guy that needs a response, in my opinion, and control of his disease. I think following radiation, I think the chemo immuno could add to the local control there if he induces a true tumor response. So that would be my preference.
Okay. So we're going to move on to what happens here, and as we mentioned, and as Dr. Socinski said, there's multiple competing strategies here. I think we have clearly the KEYNOTE-407 regimen, we have the KEYNOTE-024 regimen, we have CheckMate 227 regimen, we have CheckMate 9LA regimen, we have your Empower 150 regimen, although this is not for squamous cell, but certainly there are a lot of options.
And don't forget Empower 110.
And Empower 110, yes. So there are a lot of different options here. So do you have something you want to say?
Well, in cemiplimab from the Empower 1 trial we saw at ESMO this year. So the list is growing in terms of what the therapeutic systemic options may be.
Yeah, there's a lot of confusion, but excitement in these regimens. So this patient is treated with palliative radiation on March 19th, 2020. And we'll talk about this, and this is you'll never be off the hook on this case, Dr. Socinski, but there's 2 cycles, the patient gets 2 cycles of palliative pembrolizumab, but is discontinued due to a rash. And I don't know much about this rash, what it looked like, how debilitating it was, what it was all about. But the patient did get 2 cycles, but the decision was to discontinue it due to a rash. Don't have a clear understanding of what a lot of the details of the rash. And then the patient is switched to chemotherapy, to 6 cycles of palliative carboplatin, paclitaxel. in September 2020. And then most recently has this set of images. And I'm going to say that for one, that after the 6 cycles of chemo, the disease in the chest, which we don't see here, the disease in the chest is growing. So we've got disease in the lungs that's progressing. And then we have some findings in the abdomen as well.
We have some cuts
Sorry.
Sorry about cutting you off, Dr. Levy. We have selective cuts that are from the upper abdomen that show on the bottom image on the left, you can see that there's a small lesion that's now in the right adrenal gland. And on the upper image, you're only getting a portion of the image that shows that there's a new lesion in the left adrenal gland. So we've got new bilateral adrenal gland metastases in addition to the findings that you had noted that were in the lungs.
Okay. So the imaging showed, increasing bilateral adrenal metastases, increasing size and number of lung nodules. So we've got in review a patient who received 2 cycles, got palliative radiation to that lytic lesion, followed by 2 cycles of pembrolizumab, discontinued because of a rash, then received 6 cycles of carboplatin, and then experiences disease progression based on this scan. So Dr. Socinski, I know you don't have all the information here. Maybe walk us through, if you were seeing this patient as a second opinion, what you would want to know and how would you manage this patient?
Well, I'd want to know, I find it very unusual that you would have to continue pembrolizumab after 2 cycles because of a rash. I'd want to know really how severe was it, how was it managed in terms of preventing it. Was there any response to the disease after 2 cycles of pembrolizumab? We didn't get that information. He was just transitioned to chemotherapy. And at this point, again, this is a relatively data-free zone, I think. I'm not quite sure. I hesitate because of the very short duration of exposure to immunotherapy in someone who's strongly PD-L1 positive. I kind of hesitate to deem him progressed on immunotherapy. And that would be because, let's face it, Dr. Levy, after this, there's not a lot of great options for this patient, right? And with a PD-L1 of 80% or so, again, I'd want to give the gentleman a fair chance of having immunotherapy induce a response. Now, one could consider these, and again, this depends on how the patient's feeling, his performance status and everything. Would you consider going back to a chemo IO strategy? Would you consider, there is second line data for, the combination of like Nivo-Ipi in this particular setting. So I think those would be things that I would consider before I would go to kind of if you want to say he's failed immunotherapy, he's failed chemotherapy, the textbook answer is docetaxel with or without ramucirumab in this, and I'm not particularly excited about that.
Yeah, I think you're right. I think the further along you get in the lines, the less options, therapeutic options you would have. I would certainly want to know more about that rash and how it was managed and what was going on, because I think you and I both know that checkpoint inhibitor probably is the best drug for this type of patient with the heavy smoker, PD-L1 of 80%. We've learned that PD-L1 is a continuum. 80% is probably better than 60%. 60% is probably better than 50% in terms of how these patients do, at least based on some retrospective data. So I think that's where I would want to do some deep digging. And even potentially phone a friend, a dermatologist, to figure out, who saw the patient, what was the reasons why, because I think that's the crux of this case.
Yeah, and I think, all of us are using lots of immunotherapeutic agents in our practice today, and to have to discontinue an active drug, particularly in an 80% positive patient after 2 cycles, just seems a bit odd to me.
Yeah. So let's just do 2 scenarios here for the sake of time. Let's say, and I think we talked about this before, but let's say that instead of showing the scan showing disease, remember in this case, the patient had disease progression in both the lungs and new bilateral adrenal metastases. Let's say that this patient was on palliative carboplatin as a second line after discontinuing pembro for a rash. and instead of developing disease progression everywhere, only developed an isolated adrenal metastases and an otherwise stable disease of the lung. How would we manage this? Dr. Curran, is this an opportunity for radiation? Would you talk to the surgeon about potentially resecting this? Dr. Puri, I know this is below the diaphragm, but maybe you can give some insights from a surgery standpoint about the resection of a adrenal metastases, and so maybe from one of your colleagues.
I'll wait for Dr. Curran to go, and then I'll give you my thoughts on this.
Okay.
Yeah, so adrenal metastases are rarely irradiated, and I think that's appropriate in the case of them truly being an oligometastatic site. It's worth considering, or in the case of someone with significant pain, which is actually infrequent. Beyond that, I don't see a lot of indication for irradiating an adrenal lesion.
Okay. Dr. Puri, I'm putting you in an unfair situation, but any insight that you have on the surgical resection of the adrenal met?
Typically speaking, when we have encountered such situations in our tumor board, the discussion for adrenalectomy is in the setting of when we would provide disease-free survival to the patient, or sort of that if that's the only site of disease, and but in someone who has either persistent disease or progressive disease in a non-adrenal site, we really would not consider an adrenalectomy. It's a relatively easily performed, minimally invasive operation in most settings, but I'm not sure that that would really improve this patient's disease-free or progression-free survival.
Thank you for that. One more scenario here, back to Dr. Socinski. Let's say, again, this patient had widely metastatic disease on presentation, had the lytic lesion in the right gluteal mass, has that radiated, but the PD-L1 is not 80, but is 0. Does that change your management up front, Dr. Socinski? Or are you still going with the regimen that you were using for the PD-L1 80?
Yes, there was a very nice presentation at, I believe, ESMO last year by Dr. Borgai, I believe, was the first author. They did a pooled analysis of the PD-L1 negative or 0 population from Keynote 21G, from Keynote 189, and Keynote 407, and specifically looked at the PD-L1 negative less than 1% or 0. And I was impressed with that. I believe, if I remember correctly, the hazard ratio for the chemo versus chemo plus IO arms of that trial was 0.56 in the PD-L1 negative population. So again, PD-L1 to me is an important biomarker. It's not a perfect biomarker, and it really only has one use in my practices, and that's identifying those very high, and higher the better, patients who you might use immunomonotherapy in.
Yeah.
But if it's not, 80 plus or very high, then I tend to use chemo immunotherapy, whether it's 20% or 0% or 35% or anywhere in that range.
Yeah, probably one of the more common opinions I get is the PD-L1 0, and a lot of the people in the community are not aware of this data, this hazard ratio 0.5, not aware of the subsets from 407 and 189,
right,
showing a benefit by adding IO to chemo. Just the negative predictive value of PD-L1 is not great. Those that are zeros can still respond to chemo IO.
We know this is a very heterogeneous expression across the tumor, so you never know where you biopsy and what you may see. You can't assume that it's truly negative.
Okay. Well, this has been a great discussion, a lot of interesting points and nuances with this case. I appreciate the panel's input and expertise.